you everyone for joining us and hanging in there as we figured out a couple of technical difficulties. So just a few things for you to know. As you've noticed, this is in webinar version, so all of you are muted, but please feel free to ask any questions either in using the chat button or the Q&A button. We will be checking those periodically and working to answer them as we can. The webinar is also being recorded, and so if you there's a particular part you want to go back to look at, that will be available to you as well. My name is Amanda Mitchell. I'm the Executive Director of Epilepsy Alliance America. Epilepsy Alliance Louisiana. Lisa gets Epilepsy Alliance America. But we are a member of Epilepsy Alliance America, and I'm going to be your host, so I'll help to introduce the other panelists. And at the end, I'm also going to share a little bit of my story, as I am also the parent of a child with epilepsy. So what are we going to talk about today? A few things. We want to make sure that we know all we can about seizure action plans and why they're important, and answer any questions you have about that. Also for rescue medications. So do you have the right one, and what should you do if you're facing any challenges right now related to the Diastat shortage? And then we're going to talk more about epilepsy's impact on mental health, because it does impact daily life for a lot of people. And then finally, how do we take action? How do we put this all together to really go out and advocate and support our kids? All right, so first, and I'm going to pull up his bio, is we have Dr. Shaw with us today. Dr. Shaw completed his medical training in India and pursued his Master's of Public Health at New York University. Dr. Shaw received pediatric training at BUHMC and completed his pediatric neurology residency at Cohen's Children's Hospital in New York. He also served as the chief resident in his final year of his training. Dr. Shaw has also received additional training in clinical neuropsychology at Duke, the Duke University Medical Center in North Carolina. And I am also particularly thrilled to have Dr. Shaw with us today because he joins us from Louisiana as well. So welcome, Dr. Shaw, and we look forward to learning more about your perspective as a neurologist.
Thank you, Amanda, for your kind introduction. Can you guys see my screen?
Honestly, I can't tell if we're still seeing yours or Lisa's. So what do you want?
So I guess if Lisa stops sharing her screen, mine has a quote there.
There we go. Okay, I think now we can see yours, yes.
Awesome. So good afternoon and good evening, everyone, depending upon where you are located. My name is Dr. Shah, and I would like to start with this quote, which I like from Dr. Graham Bell, which says, "Before anything else, preparation is the key to success," and that's what we are going to discuss today. So I want to walk you through the story of one of my patients. I've changed the name. I'm going to call him as Duncan, and he's a warrior Duncan. So and then I will we'll walk through his story, and then through his story we'll try to answer the questions that a child faces in his day-to-day life when he's especially in the school, as well as at home, and regarding his rescue medications and seizure preparedness, and so forth. So let's begin with this story. So Duncan is our cute little 8-year-old boy who started seizures at the age of 2 years, and he has brain malformation. He's currently in 3rd grade. He has three kinds of seizure. One is generalized tonic seizures, where he has a stiffening episode that can sometimes happen in cluster, and then this happens once a week. Type 2 seizures is generalized tonic-clonic seizures. That means he is having shaking episodes, which is once a month. And mostly this lasts for 2 to 3 minutes, but sometimes this can last for 5 minutes. And the third kind of seizure that he also has is staring episodes, which is absence seizures, which can happen a few times a month. And for type 1 and type 2 seizure, he requires rescue medication. And to note, his seizures can sometimes be provoked by sleep deprivation and flickering lights. So what can we do to keep Duncan and Duncan's family safe and happy, especially when he's in school? So I like to discuss, I like to divide this in 4 chunks. One is general precautions that applies to everyone. Then the second is safety with exercise, sports and water, spatial accommodations, and then the seizure action plan. And I believe we can get a customized seizure action plan from our provider, and I think that's one of the most important things to do. So a general precaution, if someone has photosensitive epilepsy, the meaning of photosensitive epilepsy is that sometimes a flickering light can cause seizures. Not everyone has that. Some kids with generalized seizures have high chances of having seizures with strobe lights. So avoid strobe lights if the kid has tendency to having seizure with it. Second is avoid heights. If we recommend them to be at up to 2 feet on the ground all the times, not above that, and because that can increase their risk of having injury if they fall down with seizure. The third is limit heat exposure, and the last point is limit screen time, because sometimes prolonged screen time can increase someone having risk of, if someone has risk of photosensitive seizures, they can have increased risk of having seizures. So I'm going to discuss about sports and water safety, and these are the guidelines from International League Against Epilepsy. The task force came up with these guidelines in 2015. I'm not going to discuss all. We're just going to discuss something pertinent to today's talk, and some practical points. So in terms of sports, we divided into group 1 sports, which is which are the activity at very low risk of injury or almost non-significant risk of injuries. So that includes jogging, running, baseball, basketball, dancing, golf, racket sports such as table tennis and tennis, that everyone can do, even the kids with seizures can do, and doesn't have any contraindication. The second type is moderate risk sports, which includes archery, canoeing, boxing, karate, cycling, horse riding, ice hockey. So what we recommend is that it should be avoided if possible. Generally, we don't avoid if the child is having appropriate gears and appropriate protective gears, if they are wearing it all the time when they are doing this activity. And the third kind of activity is a high-risk sports activity, which includes mostly aviation, climbing, diving, horse racing, motorsports, scuba diving. And kids with seizure, we generally recommend to avoid this when they come to our clinic, and this is something that we try them not to have unless it's absolutely necessary, and in that case we can make some customized recommendations for them. And the good news is that in this 2015 guidelines, the good news is that if this child is seizure free for 12 months, they can participate in all the kinds of group 1, group 2 and group 3 sports if they are seizure free for 12 months. Regarding water safety, as we know, a person can drown if they have seizures in water. So they can drown if they have seizure in water, and it doesn't take much water to stop having breathing. So when they are in water, make sure that they have proper supervision, and make sure that someone is around them that knows how to swim and has life-saving skills and knows how to respond to seizures. And then in terms of showers, take showers instead of baths, because if the seizures are frequent or if there is tendency to fall down, then use a shower chair, and that can that's important for water safety. The third thing is spatial accommodation in school. I'm going to touch on the first 2 points, and our next speaker is going to talk about 504 plans and the individual education plans. So for bus safety, make sure that the bus driver and the other school personnel or aides are familiar with the seizure action plan released by your epilepsy doctor or your neurologist or your nurse practitioner. Unlicensed individuals are permitted to administer rescue medication as long as they know about the seizure action plan, and make sure that the rescue medication are there with the patient all the time, appropriately labeled and accessible to patient and the people around the child. So let's talk about seizure action plan. So what is seizure action plan? So it is a detailed seizure related information about the student. And so what we say is that every person with epilepsy may not need rescue therapy, but every person with epilepsy needs a seizure action plan. So who uses it? Every adult individual who interacts with your child on a day-to-day basis, specifically school teachers, school nurses, coaches, and other individuals with supervisory role should receive and review seizure action plan. Where it is kept, typically a school nurse serves as gatekeeper of the seizure action plan, and it is advisable for school nurse to have this seizure action plan in students' file with the classroom teacher should also have a copy, and again parents and physicians should also have a copy of it. Who will benefit? Almost everyone. The kid and the people around the child will benefit with seizure action plan. Students are more likely to receive an appropriate response. School teachers and school nurses when they have the necessary information to respond and provide the first aid when the child has seizures. Where to get it? I mean, there are a lot of resources that you can get it, but one I recommend is very wonderful, good plan, very diagrammatic with pictures on Epilepsy Alliance website that you can get from. And I will walk you through one of the seizure action plan that I generally give to my patients. It's all customized. So this is for our patient Duncan Warrior. And then it has triggers. So for this kid had triggers, for example, fever, sleep deprivation, flashing lights, patterns of seizures. So this diagram is pretty self-explanatory for our kid. However, if some patient has different kind of seizures than this seizures, then we put it here in patterns of seizures. If they have any allergies, then we put it here. And then we put some notes that when does he require rescue medication, what kind of seizures if he has, then he will need the rescue medication. Then we will point it out in this note section here. And then this is the second part of the seizure action plan, where what needs to be done when the child is having seizures. So this is pretty self-explanatory. First thing you need to do is time the seizures, keep person safe, don't restrict the child, keep if he's seizing, let him do whatever he's doing, stay with the person and keep the record. And then the second part is provide the rescue treatment, where we write exact dose of the medication, how to give the medication, what is the route of administration, and then the last part is call for emergency in the situation if the seizures are longer seizures, if they're unusual seizures, so on and so forth. And then we also give our phone number back and our hospital on-call provider emergency call number there as well. So again, seizure action plan. So after your health, when you go for your first visit or your second visit, any of the visits when you go to see your doctor, neurologist or your epilepsy doctor, make sure that you have that seizure action plan either signed at the first place, and then if you are going for follow-up, make sure to update it. And once you update it, make sure to have multiple copies. Keep one with you all the time in your purse, pocket, wallet, backpack. Put one in the central place at your home. Give few to people who are with your child more frequently, and then you can give it to definitely you should give it to your school nurses, school teachers, and And if your child is going to a camp or other programs where he or she may spend a lot of time, give a copy to a camp nurse, counselor, or person in charge. And again, during all this process, make sure that your child knows that you are doing this and this is a part of this process, so he's not left out and he knows exactly what's going on when he has a seizure. So what is rescue therapy? So we are moving to the next part of our talk is about rescue therapy. So rescue therapy is the therapy that is used to stop seizures. Either it could be, I will discuss in next few slides about what kind of seizures we use rescue therapy for. Prevent a seizure emergency. For example, status epilepticus is a seizure emergency. So we use rescue therapy to prevent a seizure emergency. And the rescue medication generally don't replace routine medication treatment for seizures. Again, rescue medications are as needed medication. They are created to be used by non-medical people outside the clinic, ER, or hospital. And currently we have 3 FDA approved rescue therapies, and there are more in development. So when do we use rescue medication? So the first is that seizure clusters, prolonged seizures, status epilepticus, and the last is high risk times. So high risk times are basically if we know a definite trigger for your child, for example, fever or infection, then the provider can work with you and give you a customized seizure action plan to when to use your rescue medications. So discussing about cluster seizures, so there is no consistent definition for cluster seizures. Different people have defined cluster seizures in different ways. However, some of the commonly used definitions of cluster seizures are if your child gets more than 3 seizures in either 24 hours or more than 2 seizures in 6 hours, that could classify as a cluster seizure. They are also called as acute repetitive seizures, bouts of seizures, or serial seizures. And sometimes they can have some warning signs such as prodrome of aura, or sometimes they can have symptoms in between the cluster seizures, for example, nausea or vomiting. And then the person returns to baseline between the seizures. They may not completely return to baseline, but they should return at some baseline level in between the cluster seizures. So let's go to next type of seizure where we require rescue medication is the status epilepticus. So status epilepticus are divided into 2 types. One is the convulsive type. So if the child has seizures more than 5 minutes, we call it as status epilepticus. And then several seizures without time to recover between them. So if seizure comes back to back in more than 5 minutes, again, it's defined as convulsive status epilepticus. It can happen with any kind of seizure. And then in some cases, particularly with symptomatic epilepsy or in early childhood, a child's first seizure can be episode of status epilepticus. And then there is a second type which is known as non-convulsive status epilepticus. This means that the patient is not shaking, visibly not shaking, but still having seizures. Mostly they can have confusion, they can be sleepy, then they can be staring. And sometimes this can be very hard to recognize. And in some cases, it is possible to diagnose non-convulsive status epilepticus with EEG. And sometimes you can't diagnose it by just looking at the child. However, if we have a seizure action plan in place, the person who is with the child will be able to know when he's having non-convulsive status epilepticus. So why do we need rescue therapy? So seizure cluster can sometimes progresses to the long seizures, for example, status epilepticus. And these repeated seizures or status epilepticus or prolonged seizures has very high morbidity because it can cause injury and it can cause because of the brain damage, and sometimes it can even cause mortalities. High rates of emergency department visits and hospitalization if we don't stop their seizures. And then again, the caregivers and the patient have negative quality of life measures if they have to again and again go to the hospital in the emergency room. So that's why we use rescue therapy. So just one slide on who all are at risk of having cluster or prolonged seizures. So again, the patients who are not controlled on two 2 or more medications, which we call it as drug-resistant epilepsy. They are at high risk of having cluster or prolonged seizures and will require rescue therapy. Epileptic encephalopathies, the patients who develop seizures in childhood with brain malformation and other genetic abnormalities. Multifocal epilepsies, if the child has multiple seizures coming from different parts of the brain, that increases the risk of having prolonged seizures. If they had meningitis or encephalitis, some brain infection when they were child. Traumatic brain injury can also increase the risk, and then if they develop seizures at very early age, that can also increases the risk of having cluster or prolonged seizures. And some of the predictable situation or provocation is that if they are really sleep deprived, if there is a lot of stress going on, fever or illness, if they missed their medication doses. Catamenial seizures are the seizures which happens around the time of menstruation, can sometimes increase the risk of having prolonged seizures, and again, alcohol and other recreational drug use can also increases the risk. So what are the medications that we use for rescue treatment? So the first, the currently FDA approved therapies are Diazepam Rectal Gel, Diastat, Midazolam nasal spray, Nasilam, and the Diazepam nasal spray, which is Valtoco. And then the off-label medications are Buccal Midazolam, Clonazepam, which is oral disintegrating tablet as wafers, and then the BNS, vagal nerve stimulator. We'll discuss in detail about the first 3 on the left. So ideal drug for rescue medication, what should be the ideal property for that medication? So first of all, they should be safe at their usual therapeutic dose. They should be potent in small volumes. It should be effective against a majority of seizure types. It should be quick, easy, and safe to administer. It should be rapid onset of action within minutes, and they should have low monitoring requirements. So if you see the table on right, just to give you perspective, if you give a medication through mouth, it will take around 45 to 60 minutes to start acting on your body. If you give it under the skin, it will take 45 minutes. If you give under the muscles, which is intramuscular, it takes 30 minutes. Rectal medications will take around 5 minutes. Intranasal is even faster, less than 5 minutes. And then the intravenous is the fastest, which is 1 to 3 minutes. So that's the reason we can't give intravenous medication, because we need a skilled person to do that. We need an IV access for doing that. So the best possible next options are intranasal or rectal route that we can use. So let's say for our patient Duncan, what should we be choosing for him? So he is now 8 years old. He is in 3rd grade. So let's discuss between giving him either rectal diazepam versus nasal diazepam. So Diazepam Rectal Gel is a semi-solid preparation. It's administered via plastic syringe applicator. This was approved in 1997, so it has been used since a very long time. We can repeat one more dose in 4 to 12 hours if he had another seizure in 4 to 12 hours. What are the pros, what are the advantages? So the dose is already predetermined, so you don't have to calculate the dose when he's having seizures. It has long-term track record as it is approved in 1997. It is rapidly absorbed in the body, can be given in conscious and unconscious patients, can be advantageous in patients with post-ictal nausea and vomiting. Some of the disadvantages of rectal diazepam gel is that it requires another person to administer. The delivery route could be difficult in some patients, especially if they are large patients, if they are on wheelchair, and if they are moving a lot during seizures, it may be difficult to administer this. And then sometimes they have societal implications. For example, the school teacher, there are a lot of kids around in the class, and the school teacher may find it difficult because of the societal implications to give if the child is older. So let's discuss about the next option, which is diazepam nasal spray. So again, it's formulated with non-ionic surfactant. It can be used 6 years and above. It can be repeated again one more time in 4 to 12 hours, same as our rectal diazepam. And then it has all the advantages that diazepam rectal gel has. And again, and to add to it, Nasal vasculature provide ample and direct access to the bloodstream, so it's slightly faster. And again, absorption is about as fast as intravenous route, and it's very easy to use. So that's the biggest advantage of it. And again, the only disadvantage would be it requires an open nasal passage. So even if the child has nasal congestion or some seasonal allergies, still we can give it as long as they have open nasal passage. So again, just to quickly discuss about rectal diazepam, because that's the one that we use more frequently, and it's so just going to give you a little bit more more information on rectal diazepam. So first and foremost thing you need to do is, when you get a rectal diazepam from your pharmacy, is that to check your dose on the display window, which is right here. The next thing you need to do is that you need to make sure that there is a green ready band present on your injection. Store at 25 degrees Celsius, around 15 to 30 degrees Celsius range, or 59 to 86 Fahrenheit. Here in Louisiana, the temperature can go up to 90s and 100s in summer. So I would advise my patients to avoid keeping in the car, because if you keep it in the car, it can get deactivated. Again, in the colder weather in Alaska and some other northern region where it can go to 0 to minus 30 degree Fahrenheit, it can again get deactivated. So try to avoid keeping it in the car. Keep one at home and one at school, and keep it with you till it expires. Even if it's not used, make sure you keep it with you, because you never know, you may have to use it. Again, this is the dosing for rectal diazepam. Generally, it's based on their age and weight. How to administer rectal diazepam? So the first is put the person on the side where they can't fall. The next is you get the medicine, and then they get the syringe, and after that you push up with the thumb and pull to remove the cap. The next thing is you lubricate the rectal tip with lubricating jelly, and then the turn person on the side facing you. And after that, you bend upper leg forward to expose the rectum. Separate the buttocks to expose the rectum, and after that gently insert the syringe tip into the rectum. And now I always like this rule of 3, where you always count up to 3. So when you inject the injection, count 3, and then slowly count 3 before you remove the syringe, and then you count 3 and hold the buttocks tightly together to prevent the leakage. So now let's discuss about Valtoco. So it's much easier to administer Valtoco compared to the 12 steps that we discussed for rectal diazepam. This only has 4 steps. So step 1 is to you remove the blister pack by peeling back the corner tab with arrow, and then remove the nasal spray device from the blister pack. Then the next step is that you hold the nasal spray device with your thumb on the bottom of the plunger, and then your first and middle fingers on the either side of the nozzle, and do not press the plunger till you put the nozzle into the first nostril. And again, you can use the rule of 3. You keep it on for 3 seconds and press the bottom of the plunger firmly with your thumb to get Valtoco in the nose. Now Valtoco comes in strength of 5 and 10 milligrams. So if someone is older and then they may need higher dose, in that case you may have to use both the nostrils. So 5 milligrams from one nostril and 10 milligrams from another nostril if you are giving 15 if that child needs 15 milligrams of Valtoco. And the next drug is Nasilam, which is approved for the kids more than 12 years of age. It's exactly similar to Valtoco. And then currently, as you know, there is some of you may know that there is a rectal diazepam shortage going on. So for the kid, especially between 2 and 6 years, where you can't use nasal Valtoco, we we need to find out alternatives. So right now we are recommending using clonazepam wafers for kids between 2 and 6 years of age who can't get rectal diazepam due to shortage. And these are very easy to use. They are wafers. They dissolve in saliva very rapidly, and so if there's a caregiver who is giving this medication, you use your dry hands, and then you just place the wafer on the side between the cheek and teeth, and then you press it, and it will automatically dissolve the tablet. And then it also acts very fast, and the dose is written here, and it's very easy to administer, and it's pretty cost effective. And then Epilepsy Alliance of America has nice videos that demonstrate how you can do all the things that we discussed. So it's very practical, very nicely demonstrated videos if you would like to learn more about it. So take-home message is that discuss with your healthcare provider about school safety, the things that we discussed in our previous slides. Get your seizure action plan, and then make sure to have your rescue medication available 24/7, 366 days. So again, equipped with all these arsenals, our warrior Duncan is ready to fight this battle against epilepsy and seizures. Hope you found this helpful, and I guess we will take questions at the end of our session. Thank you.
Yes, we can take additional questions at the end. I talked to people about putting some questions in the chat if they had some. I don't see any right now. So yes, definitely thank you, Dr. Shah, for telling us more. So just kind of to recap, Dr. Shah talked about the importance of getting everyone trained to make sure that your seizure action plan is updated and that every person who needs one has one. And then please be sure, if you have very specific questions about your child and rescue medications, to go ahead and make sure to reach out so you can get them answered. So with that, we now will hear from Ms. Caitlin Bernard Vincent. Caitlin is the Epilepsy Program Manager at Valley Children's Hospital. She is a licensed clinical social worker, and she also sits on our program committee here at Epilepsy Alliance America. So thank you, Caitlin, for talking to us more about epilepsy and mental health.
Absolutely. I'm so glad to be here. Thank you for inviting me. I just really think this is such an important topic because we know that epilepsy impacts our physical health. We see that all the time, but what we really need to focus on, as well as keeping our children physically safe, is also the mental health effects and the social consequences of epilepsy and what that looks like for our families. So why is it that we need to discuss this? We know that epilepsy has devastating social and psychosocial effects. And if we don't address those ahead of time and be proactive with it, we can really notice a decrease in our patients' mental health. So our objectives for today are to gain a better understanding of how epilepsy truly impacts our children and their families, identify the mental health comorbidities, and really describe the importance of how our schools can get involved and how us as parents can have that advocacy role for our children on the school campus. So what are some of the social consequences of epilepsy? What does it look like for our children and on the school campus and even in their homes and in our communities? We know that epilepsy affects the overall quality of life in patients and their families. We know that they struggle with emotional, behavioral, and relationship difficulties. And then we know that epilepsy constitutes a huge, significant burden to the children and their families, which really indicates our need to be proactive in our mental health services that we're providing for these children. So what are some of the psychosocial impairments that we notice either in a clinical setting or that you may see on a school campus or even in the home? With a lot of our epilepsy, children with epilepsy, we notice persistent worrying about their seizure disorder. We know overall that our children with epilepsy have a poor self-concept and a lower self-esteem than children with other serious chronic medical conditions. We know that they also struggle with a lower social competence at school, so that's peer-to-peer interaction, and that they struggle with our perceived stigmas that we see. There was a study that was done that showed that 24% of people thought that having a child with epilepsy in the classroom would actually be disruptive to their other children's learning needs. And so there's this stigma that surrounds epilepsy and has for a really long time. And we'll go over a little bit more specifically what that may look like for our kids so that we know how to better interact and create an atmosphere and an environment that's going to be one of safety for them. Another thing to kind of look at is that in another study that we talked about, more than half of the children in a particular study asked and wanted help in handling their seizures at school, talking to other people, talking to their teachers, talking to other students. They really wanted to focus on asking for that help. And then another big piece to look at is in our adolescent population, right? When we're looking at our adolescent population in terms of their developmental abilities at that particular time age, we're looking at them wanting to be independent, their driving, their ability to hang out with friends on their own, all of that. And a lot of times with our adolescents who have epilepsy, we unfortunately have to take away a sense and a loss of that control. We have to take some of that control back because sometimes we're telling them, you know, you can't drive, or we really need to make sure that we're watching you a little more carefully, whether you're with your friends or sports you're playing and that sort of thing. So we want to make sure that we're recognizing how epilepsy really impacts our children and our adolescents in their appropriate developmental stage. We know that our kiddos with epilepsy oftentimes, unfortunately, have difficulty time making new friends. And a lot of that, I think, is due to the reason that our kids naturally with epilepsy most of the time will socially isolate, right? Because they feel different from their friends. They feel like, and they know something's different. And a lot of times it has to do with the anxiety and the fear that they may have seizures on a school campus or even out in the public. And that just is a natural tendency for them to want to kind of close in and not really be out there and involved with everyone. And because of that and a lot of other things, our kiddos do experience bullying and teasing from their peers on a school campus. So it's really important to make sure that we're addressing those needs pretty early on in a treatment setting. So moving on to kind of stigma and epilepsy. And we know that epilepsy is one of the world's oldest recognized condition. And what's interesting is that it's been dated back to 4000 BC, at least written record-wise. But we just didn't know what it was called at the time, right? There were a lot of different misnomers, a lot of different stigmas, and a lot of different things that epilepsy was around. They just called it something else, right? And unfortunately, that stigma still surrounds epilepsy today. Through the fear of other people and not knowing, through misunderstanding, through discrimination. As our kids move into adulthood, some things kind of change in their job situation or maybe even on the school campus. And so we want to make sure that this bullying, this discrimination, misunderstanding, and this fear is really going to be a part of our conversation with everybody around us, because the more that we know about epilepsy, the more our children are going to have this source of empowerment on the school campus. And we do know, working in a clinical setting, that parents often withhold the medical diagnosis from the school personnel because they're fearful of their child being judged, and they don't want their kiddo to be treated any differently than anyone else. So it's really important to encourage parents, encourage the children themselves to advocate for themselves and really talk about the condition that is affecting them, not only physically, but in an emotional and a social way as well. Sometimes patients experience with epilepsy, these are a couple key things that we hear on a frequent basis and in studies. This is what they experience with epilepsy. This is how they feel. They're fearful of deterioration. They're fearful things are going to get worse. our adolescents are fearful of having to depend on other people. And as our kiddos get older and they move into the adult population, depending on other people, right? Not maybe being able to live on their own. And some of those things that with our independence that we work on building in our children as they get older, some of those, sometimes unfortunately, we have to kind of go backwards with them and really help them build on what our expectations are and making sure that they're going to be safe wherever they're going to be. Desperation and insecurity, they feel like they've lost a sense of power, shame, right? They feel bad about kind of what's going on and how epilepsy affects them, and then really just feeling different that there's something that they don't have control over, and that this is something that truly affects them and affects them with their interaction with their peers, with their family, and with the social environment outside their home. So for a long time, really when we were working with patients, physicians, patients, and everybody really focused solely on controlling the epilepsy physically wise, right? We're giving you medication, we're trying to make sure that everything's under control and that you're going to be safe. But really in recent years, we've tried to be more proactive in a sense of being able to provide early identification of some of the major comorbidities that our kiddos and adolescents and young adults face when they've been diagnosed with epilepsy. One of them is depression, and we know that depression is very, very frequently under-recognized and under-treated in children who have epilepsy, up to 30%, and I'm going to say that some of these stats in the presentation are a lot lower than they probably are because these studies are very old. There aren't a lot of new updated studies that are going to promote kind of more mental health and epilepsy. I think there should be, but I'm just going to say with a grain of salt, the percentage-wise, if I had to guess, is going to be a lot higher than what I'm presenting to you. So up to 30% of children and adolescents who've been diagnosed with seizures also have depression as a comorbidity, which means they also have depression along with their epilepsy diagnosis. And then those that have the depression, there's about 63% of children who also had an anxiety disorder. So we're looking at anxiety and depression as two kind of the biggest components of what our children with epilepsy are going to be facing with their epilepsy diagnosis. We know that there's a higher rate of suicide found in children and adolescents with epilepsy than that's found in the general pediatric population. And kiddos with epilepsy are at risk for depression, anxiety, social isolation, bullying, and suicide. And then among deaths related to epilepsy, suicide is rated as one of the top causes of death. So that's even more of a reason to make sure that we're being proactive with recognizing some of these signs and symptoms, which we'll go over next, of really how to address talking to our kids and getting them help early on. So the next slide, I've added in here a very simple, easy to read characteristics of what you may see in children and adolescents who are experiencing signs of depression. I always like to tell people depression doesn't always show up in the way we think it should, or the way that we see in movies, or maybe we've experienced ourselves, right? Not everyone is going to be crying and crying all the time and not really able to express kind of their emotions. Sometimes what we see is more irritability, more anger, right? More sensitivity to rejection. We've got the social isolation here. We've got a loss of interest in activities. Our eating may change, right? Our behavior might change in a sense that they don't really care about anything anymore. They're going to be more reckless in things that they're doing, in the alcohol and drug use with our older kiddos. And self-esteem. We already have a lower sense of self-esteem in children with epilepsy. And so some of these thoughts may be a little more increased or intense with our kiddos who have seizures. So inappropriate guilt, feelings of not being loved, hard time concentrating, which comes along with epilepsy most of the time anyway. So sometimes it's hard to tease these out, but really what I'm going to say is just pay attention and be proactive in a conversation with your kids as they get older in an appropriate way, and make sure that their sense of self is being taken care of just as much as their epilepsy in a physical sense. Anxiety is prevalent up to 34%, and I'm going to say even more in children and adolescents. They struggle with anticipatory worry, which is basically, well, I'm worried that another seizure is going to happen. What if it does happen? What are we going to do? Who's going to respond? All of these things, a kiddo, as young as 3 years old, 4 years old, can have these worries. They just don't know how to say what the concern is. Social phobias, right? So fearful what's going to happen in public. I don't want to go out in public. I'm going to stay in the confinement of my home because that's where I feel safest. And then separation anxiety from our little ones, right? They know that their parents are their safety, their caregivers are their safety. And so to move away from that in any other type of social situation, we do see that separation anxiety. Another thing I'm going to note is there was a recent study in 2021 that came out analyzing the perspectives of over 600 adults with epilepsy, caregivers, and their healthcare providers. And what's fascinating is that even though this is an adult, what's fascinating is that over 50% in every category showed that caregivers and patients reported being extremely anxious, afraid of having a seizure in diverse situations or different environments. While driving in a public place, 77% were fearful of having seizures when they were alone, over 50% when they were asleep, and 57% when they were showering. So we know that epilepsy is very disruptive to the quality of life of people, and even more important to continue to support our mental health needs in our population who is dealing and living with epilepsy on a daily basis. So now with the mental health piece, we're going to hop gears real quick. And now that we know more about kind of where our mental health is going to sit with epilepsy, where is epilepsy and our academics come into place when you're in school? There are a couple different options, and I'm going to do a very, very brief overall level of IEPs and 504s. And the biggest thing to note is we know, and the reason we're talking about this is because epilepsy often occurs in childhood. And so therefore it's most likely the most common neurological condition that school professionals are going to encounter. And so that's so important because we really need to partner with the school to create a plan and make a profound difference in making sure that our kids with epilepsy on the school campus are set up for success. There's a couple different ways that we can do that. And I'll go over those in just a few minutes on what to look for as a parent and what conversations to have as a parent. So really, studies have shown that epilepsy has some pretty common academic struggles, some things that we're going to notice that may play a part in our children's learning who have epilepsy. So it's just important to note that anytime a patient's having a seizure, depending on which part of the brain, right, the seizure is impacted, our memory and language impairments is a big one. And up to 70% of children and adolescents will struggle with memory impairments, and that's not including any of the medication that might be somehow having some side effects for them or whatever the case may be. That's really because of the seizure. And then our attention. We know that it's a very common academic struggle with attention. We have a lot of comorbidities as far as ADHD and our epilepsy kiddos. So just kind of paying attention to that. We know that epilepsy overall has been found to negatively impact intelligence, processing speed, the attentiveness of the child in the classroom, their ability to perceived organization or making sense of things that you see on a quick basis, and then really self-regulating. They struggle with these different factors while in the classroom setting. On the next slide, I have a really cool little graph that we'll go over. We're not going to go over all of them, but it's here for you to look at a little bit more in depth. But it really goes over what are some of the common things that we see in an academic setting on the different types of learning disabilities, anxiety, depression, things to look for that specifically in studies have shown to affect children and young adults and teenagers with epilepsy. So really, what is an IEP, right? What does that even mean? You hear the word thrown around all the time, and each state offers IEP education and IEP supportive services to children and their families on the school campus. But what really is it? And what do we need to take from this? And what do we do with it? So basically, in a broad spectrum, an IEP is where a child can qualify for special education services. Okay, so a child is going to receive a full individualized evaluation by multiple specialties. And that's really going to determine if a child's going to qualify with one of the 13 disabilities that are listed. And the biggest piece to take away from this is that, does your child need special education services? So even if they have epilepsy, if their intellectual disability, their cognitive functioning, their speech, if there's something that's not being affected through the epilepsy, then they may not necessarily qualify for an IEP. We have a lot of patients who don't qualify for an IEP. They are academically on target alongside their peers. And so really an IEP is for those kiddos who are falling behind, cognitively speaking, and needing those extra pull-out services or services in the classroom to help them succeed. The biggest thing with an IEP is that the school is required by law to be reviewed annually. And the purpose really is to set specific, reasonable learning goals that are defined by the services that are going to be set up, the interventions that are going to be set up to make sure your child meets those learning goals through multiple different ways: accommodations, modifications, and support services. The biggest piece I want to make sure that people take away from an IEP is there's a big difference between accommodations and a modification. The biggest thing is that an accommodation changes how the student learns the material, but it does not change the material itself. And that is going to be what's the focus, in a 504. But an IEP makes modifications. Okay, an IEP allows the school and the parent and the teacher and everybody on the IEP team to make modifications and changes to what the student is being taught or what they're expected to learn. So the basic difference is, with a modification, it's going to change the expectation. For example, if a child is trying to learn multiplication problems, the child may just be expected or modified to only do addition problems. So there you're changing the actual academic expectation of what that child is going to be learning for the school year. And an accommodation isn't going to change that, but maybe in the multiplication, in the same situation, maybe in the multiplication, they might provide you with different tools and different things that might help this child learn that same expectation a little bit easier. So that's the difference between the two. So a 504 is very simple in that it's a blueprint. It's just a quick blueprint, but how the school is going to support a student with a disability and remove the barriers to learning, which is basically making those accommodations, right? You're not changing the learning, you're going to remove the barriers. And when does this fall into place? A lot of times, when a student isn't benefiting from instruction, when they return to school after a serious injury or a mental impairment, right? So epilepsy will qualify with that. And then they're not eligible for an IEP. So our suggestion, or I always suggest personally, that if a kiddo does not qualify for an IEP because maybe they're functioning a little bit high, we always suggest that they have a 504 in place. And that's really, really to make sure that if they're missing school days, if they need to catch up with work and they're not going to be penalized, and their grades aren't going to suffer because of that. Maybe we're going to be addressing some medication side effects, kind of like drowsiness or attention concerns. So really, the 504 plan is set up in place if your kiddo is not going to qualify for an IEP, but there's some other things that we're going to be looking at and making sure that they have the appropriate services in place on the school campus so that they meet their academic success as high as they possibly can. So 2 slides from now, I have a list here of examples of accommodations for 504s. A lot of parents will say, well, so my kid doesn't qualify for an IEP, but I don't even know what to ask for. What can be put in place to make sure that my child is going to be successful in the classroom? And really, This is just a brief list of kind of the things that we've noticed that have been helpful for our kiddos, and then all the way up through teenage and high school, is really kind of simplifying instructions, right? Sometimes it's too complicated, and they're already having issues with memory impairment and processing. So if you throw a whole slew of information in front of them, it's really hard for them to follow along. Another thing that's going to be helpful is sometimes providing teacher notes. This is mostly for our junior high and high school kids on campus, where sometimes by providing them teacher notes, it really is going to help them prepare when they're studying for a test, because they're going to know they're not going to be worried in class that maybe they're not paying attention enough or they miss a big chunk of assignments. So that's going to help them when studying, that they have all of the information they're going to need to prepare themselves appropriately. Extended time on tests. Tests for understanding, not necessarily for facts, right? So a lot of times if you're asking them to put it in a situation where they're explaining in a paragraph, it might be really hard to recall those words the way that they need to in order to implement it on the page. So maybe just questions understanding factual information about what they're expected to learn is a little bit more helpful for them. Modified textbooks, audio recordings, things like that are going to help them be successful in the classroom, versus just saying, well, good luck, catch up, and I'll give you a week to catch up. That's not always helpful. So we just encourage parents to talk to their child's teacher and the 504 team and saying, hey, what can I do? What can we put in place to make sure that my kid's going to have enough support services that's going to help them learn to the best of their ability. And then really kind of to close it all up, what's the difference? What's the big difference between a 504 and IEP? What's the takeaway? And I'm going to say, basically the biggest takeaway, you guys can keep this to look at, but it's really important that if your child is cognitively appropriate and able to participate in their 504 and their IEP meetings, that they do so. Like the doctor said before, even with their seizure action plans, we want the kids to know what's going on and what services are put in place for them, because they can actively be involved in these conversations. And really, why are we going to put support services in place that they don't find helpful? Right? They're the ones that are dealing and working through these challenges on a day-to-day basis. And so really, if your kids can participate, it's really important that you do include them and you do let them have a say if possible, so that they get the best out of the accommodations and everything that's going into place to help them be successful.
So thank you so much, Caitlin, for sharing more about that. So just again, to kind of recap, Caitlin shared with us a lot about some of the psychosocial concerns that we have for our kids with epilepsy, ways to look out for, those that are struggling, particularly with depression, and also the very important things between the IEP and the 504 and what those can look like. So to wrap this up, and I know we're at 4, so I only have my slides are pretty short, and I do still see that we have a couple questions to go over at the end. But I just wanted to take a minute to talk about putting all of this together. So as I said, my name is Amanda Mitchell. I have a master's of public health. I'm the executive director of Epilepsy Alliance Louisiana. But a lot of times I come here as my most important job as a mom of a kid with epilepsy. So I have lived through a lot of these challenges. And these are some things that I did even before kind of joining in a professional role to help our family. So the first thing we want to remember is that we don't have to do this all alone. We were never meant to, as not even as just parents of kids with epilepsy, but just as parents and as moms. We're often expected to do it alone, and it can be really hard to ask for help. Sometimes we don't even know who to ask for help. So that's part of what we're doing today, is looking for who we can ask for help. And so one of my first recommendations is to try and get local help. So Epilepsy Alliance America has 15 members across across the country. And so you can see them listed here on this map. And I know we're adding even new members as we go on. If you are joining us from somewhere that does not have one of these local organizations, you can call our Epilepsy Information Service line, and the number is listed on the slide. Or if you're in one of those states, be sure to type in epilepsy support and the state of your name and the name of your state into Google and see, what you can come up with. Maybe there are more things than you're aware of. And so the next thing that's I think is really important is to become an advocate. So I love this quote on the side. It is, diversity is a fact, equity is a choice, inclusion is an action, and belonging is an outcome. Your children, our children, have the right to be included in school. So there shouldn't be any hesitation or shame in doing that and becoming an advocate for them. Caitlin mentioned a lot about IEPs and 504s, but just to give you a kind of different view, there are two laws, the Individuals with Disabilities Education Act and the Free Appropriate Public Education law, and those are the laws that protect us. So we do have protection for our kids with disabilities in schools. And oftentimes you can go through the 504 and the IEP process and you do not agree with what the school has done. And if that happens, you have two options. You can again look for that local support. So I know exactly what I would recommend to do if you were living in Louisiana and that happened. But since I knew people would be joining us from across the country, I went ahead and tried to find a national resource. So if you go to the website that's listed in there in blue, the .gov one, you can actually search by state. And what you're looking for is to search by state and then look for state agency and your special education agency. I did a couple of test runs on different states and it wasn't always easy to find, but almost every single one had a search bar. So type in the word dispute and it will come up and then it will tell you how to dispute anything you don't agree with that may happen in public schools. The other thing to be aware of is that 19 states have passed laws specifically to protect children with epilepsy and seizures. Louisiana is one of those states. I don't have a list of all 19, but if you're interested in learning more, or if you know that you think your state does not have these laws and you would like to see that happen, please go ahead and join on Facebook, the National Epilepsy Advocates for Seizure Safe Schools. This was started by a group of moms, including one, her name is Colleen. And I worked with Colleen to help pass this law in Louisiana, and we are already seeing the benefits to families. So just however you can, in whatever way you can, to remember to be an advocate for your kid. And so the last thing I wanted to do is just go over my checklist. So those are my two kids right there on the side. That's what our pictures typically look like. Lots of chaos and lots of fun. So my youngest son is the one with epilepsy and he just started kindergarten. So to start to prepare for kindergarten, we started to practice new skills that I knew that would be important for that. So for instance, opening his lunchbox and opening snacks. In our house, we have all the social stories, all the feeling books, which I love, kind of relates back to Caitlin's talk about, the psychosocial issues and depression. So talking about feelings is something we do in our family to make sure that our kids can name their emotions. The other thing we did is, in addition to having the entire school trained in seizure first aid and safety, I also did individual training with his teachers. So with each of his teachers, I reviewed the Seizure Action Plan. I brought real videos. So Jack does have a variety of seizures, and I wanted to make sure that they were going to be able to identify what his seizures look like so that it would be easier for them to respond. And then I also provided them with books about kids with epilepsy and kids with disabilities in general. So these are children's books, and they are going to read them to the class with the hope of being to help the class understand that, again, people are different and what that looks like. For Jack specifically, the other thing we did was we asked for an early visit to the classroom. Kind of that, again, Caitlin mentioned it, the sense of kind of really having trouble seeing all the things in space and really getting overwhelmed. So we felt it would be really helpful for him to just see the classroom without any of the other kids present. And so we did. He met all of his teachers, and they were able to go over some really simple stuff with him that he would need to do there. We also set up the My ID. I'll go over that in a little bit more in the next slide, but it is a way for his teachers, or if they need to call emergency services, to basically have a list of his medications. For Jack, we also made a visual schedule. We found this to be really helpful when he's learning new skills. And so we took pictures of the teachers, we took pictures of the classroom, the playground, and then we're really able to discuss better what's happened at school because I'm able to take the pictures up at home and talk to them individually. The other thing that I like to remind people is if your school has a pickup list, include anyone and everyone you want on that list. So our family lives about 2 hours away from us if something were to happen and we need a family member to pick up our other son. We wanted to make sure that someone else could pick him up as well. So we do have friends in our town who can pick up our other child if Jack were to have an emergency. We reviewed our after school therapies and our activity schedule just to make sure that all of it fits, right? This could be a job in its own, trying to plan all of those things. And this is something I put on there as a reminder for me to always do it earlier than I think I should, because it takes a bit of time. And the last thing I did was actually to prepare his older brother's teachers. So we know that siblings get left out of this conversation a lot, and they're impacted. They see it, they understand it, they have a lot of fears and anxiety around it. So I just had a really quick conversation with his brother's teachers about some really proactive ways to help him. One of the things that we use in our house is that it's really important to be kind, but it's the grown-up's responsibility to take care of seizures. And in that way, we're not putting that responsibility, even though oftentimes it's felt, right, and it's a perceived responsibility, but we want to make sure that we're able to address it in a really kind way for the kids. So that's our list. And I know, I have a kindergartner. Your kids may be a variety of ages, but hopefully this kind of helps you to think about what you can add to your list. So I did want to go back to that My ID program because Epilepsy Alliance America does have a coupon right now for $35 to get one. So if you go on their website, you can get a coupon for $35 off. And what it will help you to do is to get one of these products. You can see they have the one on the watch band. On the back of it, it has a QR code. And so if your child does need to be seen through emergency services, then they can actually take their camera and take a picture and then pull up medical history. So it'll have medications, it'll have any allergies to both medications and foods. If there are additional conditions other than epilepsy, you can list them there as well. So this makes me feel a lot more comfortable that if something does happen and we aren't able to get there to the school before EMS arrives, that they'll be able to have that updated information. I've done it, it's really easy to set up, so I definitely recommend going look through it. And then our last thing is just to remember that we do have resources available for you. So Epilepsy Alliance America has the back to school checklist, the Seizure Action Plan, the rescue medication videos, the trust posters, so that kind of explains seizure first aid and safety in a really short way. The My ID coupons, and the seizure first aid and safety. And Lisa, listening to Dr. Shaw, one thing that I would like to share, either online or just with the participants here, is you can also get the sports guidelines for the International League Against Epilepsy. When I do our school nurses training, I always share with them the guidelines. So this can be really helpful when you're navigating playing sports in school. And with that, I think we can go on to our questions. So I saw that Dr. Shaw was answering some of them in the chat, but just in case anybody else had the same question. The first one was asking about clonazepam as a rescue medication. And so Dr. Shaw responded that it is an off-label use, but currently because of the shortage of rectal diazepam, they are prescribing it. And then Caitlin, this next one I think would be a really great one for you to answer. And it was a question about discussing Suda with kids.
Yeah, absolutely. Our doctors are very proactive where we are having that conversation with families. And, it's very tricky when you've got, I don't think it's necessarily something we're going to talk about, with little ones, but age appropriate, and having that conversation with parents, and just making sure that they're aware of what the risks are, and making sure that they take their medications on time and they come to their appointments, and really all of those protective factors that we want families to put in place, is going to lessen that risk, right, or that chance that it possibly could happen. But it's important for them to know, because we need them to know that epilepsy is a really true thing that we're having to deal with. It's not something to dismiss. It's not something to ignore. And we do want it to be treated. And so it's not meant to scare anybody, but it's really meant to educate them. It's meant to have that conversation so that they're aware of the possibility with any medical condition, right? You need to know how to be proactive with it. And that's the conversation that we have with them.
Yeah, it's a really hard conversation to have, and it's a really hard thing to learn, especially if your child has risk factors for it. But I do hope we continue to have that open line of communication with our providers, so that we can develop those trusting relationships and then be able to answer the really important questions. So does anybody else have, from the participants, did any of you have any additional questions? Okay, well that is the end of our presentation today. So thank you all so much for joining us. Thank you, Caitlin and Dr. Shaw, for being our presenters as well. And just a quick thank you as well to Neurelis, who provided some grant money to support this program today. So thanks everybody, and hopefully we'll see you at the next webinar.